have an interesting question for Professor Chung. Fluid ascites is a good environment for HIFU. For those patients who are not cirrhotic and they do not have ascites, would you recommend? I'm just thinking out of the box, doing something like peritoneal, infusing fluid, like what we do in blunt abdominal trauma, infuse fluid and do HIFU.
Well, in some patients, tumor locating at segment 8, superior area when there is a rib and also lung right in the way. So we give artificial pro-effusion. We instill saline right into the area and give it a very good tunnel for ultrasound entry. Yes. So in short, we do infuse. Right?
So how much saline do you infuse?
Usually we give a 500 ml right of saline, and that will give you a good channel for the ultrasound. Right?
Thank you. Professor Ahmed, my question to you is, have you done HIFU treatment for pre-malignant lesions of the pancreas, like IPMN, or even, let's say, MCM, or mucinous?
Yes, I did a mucinous tumor twice, but of course it's a tricky procedure because we have a cystic component. Usually we hit the solid component and the margin of the cystic component, but I think this is a very primitive experience. I can't evaluate the effect. We got a stable disease, but I didn't get a very good improvement. But I had a stable disease for this young lady. I did maybe 2 or 3 sessions along 2 years for cystadenoma. But most of my cases are adenocarcinoma, locally advanced adenocarcinoma.
Thank you, Professor Ahmed. I have an question for you in the chat box. Has there been any work on lung cancer, HIFU therapy for lung cancer?
The lung cancer, we did a chest wall metastatic or the extra thoracic component of pancreas tumor. But of course, we can't do a lung tumor, lung cancer, because of the air around it. We can't reach the central tumors. It's unsafe to apply the HIFU in lung, for my experience. But this is difficult to apply HIFU in lung tumors in spite of chest wall invading portion.
How about flooding the pleural cavity initially with water or saline and then evacuating it after the therapy? Is that feasible?
I think this is a very complicated procedures, and I don't know one doing this. I saw some work from I think from Hong Kong doing an pleural effusion to protect the lung in hepatic dome lesions, but not in the lung tumors.
Thank you. Any question from the audience? Yes, Dr. Professor De Vera.
Thank you very much for our speakers for that wonderful lecture. For Professor Hemin, is there any difference in the learning curves between the non-sonologist and sonologist clinician? Is there any difference? Do they learn the same? Do they have the same learning curve?
Okay, thank you for the question. I think this is totally different. So there is some differences between these different people. Because you see there's all of this hive training, hive treatments is just under the guidance of real-time ultrasound imaging. And if they familiar with this ultrasound imaging, it's very quickly. And also for the different indications for example, for gynecologists, our treatment, the uterus is about on the uterus, and the pelvic is much. I think is much simpler than the liver. So this is just a stage one for the malignant. Yeah, for the malignant, for the benign one, and then for oncologists, yeah, most of the tumors is just liver cancer or pancreas cancer. Yeah, it's much more complicated. So, just for stage one, the easy one, and the step two, the difficult one. So it's different. The learning curve between the gynecologist or oncologist is different. Yeah, for oncologists, I think it's longer than gynecologist.
So you're trying to say the non-zoologist learns slower than those who are familiar with the ultrasound or
Sorry.
those who are not familiar with ultrasound as a clinician, they learn the learning curve is quite slow.
Yeah. They take some time to familiar with ultrasound imaging. So later I will show you the simulation system. We have think out on some of the solution for this problem. We are shorten this familiar procedure. Yeah.
Yeah, thank you. Then for Professor Chung and Professor Hamed, do you routinely do preoperative tests for HCC or hepatocellular carcinoma prior to the HIFU?
Oh, for patients who has small tumor cannot localize, giving taste is a very good options. But usually we do not give. But although there is a report saying that the use of taste before HIFU actually improve the ablation effectiveness, right? So, but it also really depends on the liver function of the patient, whether the patient can tolerate. But I think this is individual patients' decisions, and we have to make before surgery. So I think we do not routinely perform in every single patient, but if needed, we will give taste before HIFU.
Professor Hamed, do you do pre-operative
Yes,
pre-HIFU?
I did for some cases, but of course, this is guided by the tumor size. I have cases with maybe 9 centimeter. It's responding very well for the taste, and we have a very small marginal nodules active. We did a HIFU for this nodule, but this is not a routine protocol for the treatment. We make it in selective cases, especially if we have a larger tumor. This is will add a good value for the treatment.
Yeah, because my question, the reason I asked that is because like for uterine fibroids, they usually give oxytocin to decrease the vascularity and you have a faster ablation rate. So maybe will that also work for a very vascular hepatocellular carcinoma so that you could decrease the time of the ablation?
I think that could be a synergistic effect, right? That's true. But many of the patients on standard protocol for recurrence cancers, they have a first treatment will be TASE. And after TASE, we found that some of the lesion is controlled, some are not. So we can add on HIFU. So from that aspect, right, it's actually the answer is yes, right? But for a patient who is straightforward, can be ablated, we usually do not wait until the patient range for section of TASE, and then we will give a HIFU first, right?
Recording in
combinations
progress.
with TACE, or maybe in near future in
Mhm.
combination with systemic therapy, immunotherapy, right? So that will be a longer maintenance method of keeping the patient with a disease-free condition.
My yeah. But you say you have 100 patients with hepatocellular carcinoma. How do you choose which will go for surgery and which will go for HIFU treatment? Do you have any protocol?
So high surgery is always first, right? And then the different sort of ablation, and then the HIFU is one of it. I think HIFU is between ablation and TACE,
Mm.
right? But now we also have very powerful immunotherapy. So this is become a good era. We have a combination of treatments. So that clinician has to be used and use this modality very carefully, and we have more options to treat patients with cancer with a hope of cure.
Thank you. Professor Hamid, maybe.
Yes.
Professor Ahmed,
Yes.
any response to that question?
I think we have a guidelines for treatment. The patient is amenable for surgery, is not suitable for HIFU, and the patient suitable for locally ablative procedure is not amenable for surgery. So, as my dear professor told us, we have a guidelines like Hong Kong classification guidelines. We use the HIFU as an ablative procedure. So what we want in the next era to make it like not radio frequency, not microwave, we use an ablative, and this is starting now in Barcelona clinic. They told the ablative procedure. Who is clever in any ablative procedure can use it. But for my opinion, the HIFU will have a very important role in combination with the immunotherapy, because in growing rule of the immunotherapy, the HIFU may be a combination, because at this point we don't aim for a complete ablation. And I showed you some cases for liver metastatic lesion in combination with the immunotherapy and the chemotherapy. And I think will be the future for the application of the HIFU. We will not use the HIFU as a definitive curative way only for the treatment. It's maybe an adjuvant to improve the other type of treatment.
Thank you very much. There are so many participants here. Professor Min, would you consider off-campus training of HIFU soon?
Yeah. Maybe half an hour, half an hour later was that.
Half an hour later. So with certification. Thank you. We would like to thank all our experts, Professor Chung, Professor Min, and Professor Ahmed. Thank you very much.
So we're running a little bit late, but to close our morning session, we would like to call the head of the HIFU unit at St. Luke's Medical Center, Global City, Dr. Ramon De Vera.
So good afternoon. We started with good morning. So our conference has come to an close, and I'm sure this has been a most fruitful time for us in the on-site and on the online participants. So this conference, I'm sure, has set for us another step in the treatment algorithm of our patients. And I'd like to thank our speakers for this conference, Professor Decam, Professor Yan Tapan, Professor Lian, and Professor Selva, Dr. Wang Si, Professor Ahmed, and Professor Tancho Chung, and Professor Hamid Limin. Thank you very much. So have a very pleasant afternoon, and maybe
This is our morning session. So for all the participants, kindly scan this QR code. This will please accomplish the survey in the evaluation form. And may we also announce that all participants for this morning for the Congress are also invited to attend the lecture this afternoon. You may come back at 3:45 till 5:30 for the lectures of Dr. Selva and Dr. Hemin. And also, there's going to be a little gift for all the participants from China. So please don't forget to get the token gift I think it's there in the registration table.
Recording stopped.
So before we end, may we request everybody to come to the front so we can have our group picture taking. Okay, so may we ask everybody to come forward, or come here in the front and up the stage so we can have our group picture taking. Yeah, maybe stage. Take this background. With this background, so some people will stay up in the stage? Yeah.
Here in
Yes.
front of the.
Yes, please.